Welcome to the latest installment of the National Telehealth Resource Center webinar series. It is produced by the National Consortium of Telehealth Resource Centers that include all of us. Today's webinar is making video visits personal, implementing and scaling with your own providers, brought to us by the Franciscan Missionaries of Our Lady Health System in Louisiana. Next slide. There are see the map, there are 12 regional telehealth resource centers and 2 nationals. We serve every state in the nation and territories in the Pacific Basin. We provide technical assistance, outreach and education to advance telehealth with particular emphasis on rural and underserved areas. The 2 national centers are one for policy. They keep track of policy federally and from state to state because it is very complex. And then the Telehealth Technology Assessment Center is our national center for technology that has a wealth of information about connectivity equipment. And then in each region, we work to keep track of the environment, the telehealth environment in our region. Telehealth Resource Center is the host today, and we serve all of Texas and Louisiana. Just a few housekeeping items. Your phone or computer microphone has been muted. If we don't reach your question, please contact your regional telehealth resource center. There may be some delays in response time. We are, as you might imagine, extremely busy with the COVID-19 issues and waivers for telehealth. Please fill out the post-webinar survey. The webinar is being recorded and will be archived and will be available. That archived webinar will be available on the YouTube channel. Next slide. We are considering CMEs for some of these webinars, so we will be asking some poll questions toward the end or during this webinar, so we would appreciate your feedback for those. Okay, our speakers today are Kacy Crittenden, Director of Ambulatory Quality for Our Lady of the Lake Physician Group. She supports the physician group as the Director of Ambulatory Quality. Her areas of responsibility include the development and implementation of workflows that support the goal of achieving the triple aim. She supports a unique team that has daily touch points with patients and works to promote preventative care and screenings. She recently received her Master of Applied Science in Population Health Management from the Bloomberg School of Public Health at Johns Hopkins University. She and her team were instrumental in enabling the rapid scale of video visits across the health system in the midst of COVID-19. Dr. Chris Deniz is a Medical Director for Quality for the Lake Physician Group. A native of Baton Rouge, is a graduate of Louisiana State University School of Medicine in New Orleans. He completed his postgraduate training at Baylor College of Medicine in the Texas Children's Hospital affiliated Pediatric Residency Program, during which time he served as the Ben Taub Hospital Neonatology Chief Resident. He has practiced general pediatrics with Our Lady of the Lake Physician Group since August of 2000. He serves as faculty in the Our Lady of the Lake Pediatric Residency Program and was awarded the inaugural Golden Apple Award for Outstanding Teaching. He was named the first medical director for quality in 2014 for Our Lady of the Lake Physician Group. He has served as medical director for community care since that time. He is an outspoken advocate for virtual health and a leader in the push to expand video visits. He resides in Baton Rouge with his wife and 2 children. Next slide. Then Jenny Smith is Director of Digital Health for Franciscan Missionaries of Our Lady Health System. She currently serves as the Director of Digital Health, where she is responsible for the development and implementation of a system-wide digital health strategy. She is a past chair for the Louisiana Task Force on Telehealth Access and a member of our TexLa Telehealth Resource Center Advisory Committee. Jenny received her Bachelor of Science degrees in Information Systems and Decision Sciences from Louisiana State University and her Master of Science in Information Systems from Middle Tennessee State University. She's built her career around enabling access to quality care through technology. And with that, I will turn it over to Jenny at this point.
Thanks, Becky, and thanks to TexLa and all the telehealth resource centers for giving us the opportunity to present today. I also want to say thanks to Kacy and Dr. Funes for presenting alongside me today, because I think their perspectives are important aspects of how we have implemented and scaled the video visits. So by way of agenda, I just want to take a minute, give you some background on who we are as an organization, what drives us, talk about our virtual visit journey, give you the perspectives from Dr. Funes and from Kacy, and then spend some time wrapping up and taking questions. Franciscan Missionaries of Our Lady Health System is one of the largest healthcare systems in Louisiana. We're a nonprofit Catholic organization that is very mission driven, and primarily we focus on extending the healing ministry of Jesus Christ to those most in need. We're the leading healthcare provider for much of Louisiana, more than half of Louisiana's population. And you'll see from the graphic there a sizable portion of Mississippi around the Jackson area. Our ministry started in 1911 when 6 Franciscan sisters came to Louisiana, and in 1913 opened our facility in North Louisiana, St. Francis, and it's still there today. We are headquartered in Baton Rouge, Louisiana, and we serve both states through a variety of ways. So our video visit journey started many years ago, but in earnest really probably in 2017, and I wanted to spend some time talking about the guiding principles that we established from the beginning of this journey. So from the outset, we knew we did not want to outsource the provider side of the video visits to a vendor, and pretty quickly decided we also didn't want to outsource the technology in a way that wasn't going to be integrated with our EMR. It was important to us, and still is, that our providers be able to see their patients virtually, and that our patients be able to see their providers virtually, not to replace in-person visits, but as an alternative access point for those patients. We also wanted to be sure that we started with our established patients. We had some providers that had trepidation around starting with new patients, so we wanted to be sure we started with those who had a relationship with the providers already. I mentioned the EMR. We have made a sizable investment in Epic, not just from a financial perspective, but time and resource and team. And just, we didn't want to have a solution for video visits that was outside of that. Our providers, our front desk team members, our MAs, nurses, they're living and breathing in Epic. We're driving our patients to MyChart for a variety of things. We didn't want to then say, use Epic for this, but for video visits, use a different functionality. So that was key. We also wanted to replicate in the virtual process what we're doing in clinic. So we wanted our patients to be able to sign the consent forms, to update their meds, their allergies, their demographics, those types of things in a way that was familiar. It was seamless for the providers, for the clinic team, for them to be able to have that information during the rooming process. We wanted our patients to be able to do copay and not have to receive a bill on the back end, things like that. Speaking of copay, Louisiana actually has a pretty good reimbursement landscape as it relates to our payers and how they handle telemedicine and video visits. So from a patient-facing perspective, we didn't want to charge patients out of pocket when it could be covered by insurance. So we were intentional about building a process that allowed for that billing and reimbursement. We also started with a list of approved conditions. We had providers who were not only hesitant about seeing new patients, but hesitant about video visits being okay from a clinical perspective. And so they wanted some guardrails around what can we do by video? What are those conditions that we can see by video? And Dr. Funes was one of many providers that were on a work group from the beginning to say, this is what's okay and this is what's maybe not okay from a Catholic perspective, from just a virtual care perspective. And so we created that list. We've pared it down to a list of symptoms that I'll show you on the next slide just to kind of give you an idea of what we are seeing by video. It was also important that we have a seamless connection to follow-up care. So if one of our patients saw a primary care provider by video, Dr. Funes, for instance, as a pediatrician, and he felt like that patient needed to see a specialist, he could refer that patient seamlessly in that conversation. He had access to the patient's record. He knows the providers. There's that trust built with the patient to be able to say, hey, I want you to see this specialist. I'm going to refer you to somebody. I trust this person. Versus if we had outsourced that and we weren't using our own providers, that third-party provider may not have access to the patient's history, wouldn't necessarily have relationships with our specialists and our providers, and so it wouldn't be such a seamless connection. It was also important that we keep the patient and the revenue in our health system. We are mission-driven. We are patient-focused. Our patients want this functionality, and they've wanted it for a long time, not just since COVID. So we didn't want them to have to look elsewhere. We wanted to be able to offer that to them and keep it within our health system. So just so you have an idea, these are the approved symptoms that we say are okay by video visits. And when we started this, we saw most of our providers start with the follow-up for ADD and ADHD or the anxiety, behavioral health issues. They were less comfortable with, what if I can't touch the patient? And we've seen that change over the years, but initially that's where we saw a lot of our providers start. Having physician champions, which I'll talk about in a little bit, was helpful because they could come alongside and say, no, this is why this is okay. This is how you can do this without capturing the vitals, or here's a way you can capture the vitals. Some critical to success factors. These can be interpreted in a couple of ways, right? If you look at them in the reverse, like this is what we felt like helped us be successful. The flip side, they can be lessons learned. If we didn't do these, I think we would have really, really struggled. The other way to look at this is there's success factors, but they were also part of just how we did business. It was part of the workflow. It was part of how we implemented. So I wanted to spend some time talking about how we structured our rollout. First and foremost, physician champions. So we started by identifying a handful of physicians that were in this no matter what. They saw the value. They knew we may have bumps along the way with the technology or the protocols or whatever it is. They weren't going to throw up their hands and walk away and say, this is terrible. They were going to help us work through that. Another key component is, as director of digital health, I can speak to physicians all day long and tell them why video visits are okay, how to document, how to not be worried about malpractice, or whatever the concerns may be. But it's different coming from me, and this is not a bad thing. I recognize that I'm okay with it. It's different coming from me than if it comes from a physician. The physician knows their space. They're in that same boat together. They have the same concerns. They have the same care about how to treat a patient. So having those physicians champions to come alongside and answer those questions and speak doc to doc, it was just, I think if we hadn't had that, we wouldn't have been successful. Continuity of care. I mentioned this a bit at the beginning. Using our providers enabled that continuity of care. And one thing I've thought about is having access to the record, even the video visit. We're within Epic. When we start that video visit, the provider clicks connect, the patient clicks connect. It's all seamless and part of the integrated workflow. Having all that documentation in one place for the handoff and the trust that comes along with that handoff to the specialist not only makes the patient experience in that primary care visit good, but when they get with the specialist on the back end, that specialist is not having to create a history from scratch and build that history. They're building upon the history that's already there. And that continuity was very key to the adoption. this next one, making the process easy. What I keep thinking about is, if it's not easy, it's hard. And we did not want this to be hard. We didn't want it to be burdensome for our providers, for the front desk schedulers, for the MA and the RN that's rooming the patients, for the patient. This needed to be something that was just easy for them to integrate. Patient at 9 o'clock is going to be in person. It shows up on the schedule. Patient at 9:20 shows as a video visit. We see the patient is checked in. It's just part of the normal workflow. It's easy. The physician can see the in-person visit at 9 in the exam room and then see the 9:20 by video. And that patient has already been roomed virtually. The provider just comes in and picks up the workflow. To make sure it was easy, we were very intentional about spending a lot of time on training and testing and adapting to what we learned through training and testing. Pre-COVID, we spent a lot of time at the elbow with the providers and their clinic team to make sure they were all comfortable with every step along the way, and then through go live. So if the patient had some if the providers had patients scheduled for go live, we were there during those initial visits. We didn't walk away until they were comfortable, and they all had our cell phone numbers if they weren't comfortable afterward. When COVID hit, we weren't able to maintain that, and so we adapted our training a lot, leveraging resources like Kacy's team that were in the clinic, had relationships with the providers, had relationships with the patients, and could help us get that, have that hands-on approach. We also created videos that we could share with patients. This is how you download my chart. This is how you schedule a video visit. This is how you complete a video visit. And we leveraged, again, those physician champions to have provider training throughout the big push when we had everybody live. We leveraged those physician champions 3 times a day for 2 weeks to do training sessions and answer questions with the providers. Seamless integrated workflow. I've touched on this already. It was so foundational, especially when the pandemic hit, because when it hit Louisiana, it hit hard, it hit quickly, and that's probably not unique to just Louisiana. Because we had a foundation already in place that was a seamless integrated workflow, we just had to build upon that, and we were able to do so quickly with the tools that we already had in place. Another critical factor is you have to measure and determine whether or not you're being successful, whether or not you're being effective. But it wasn't enough to measure. We wanted to respond to what we were learning. So I won't touch on all these, but 2 in particular, we wanted to not only know which providers were live, how many have we gotten live with functionality, but how are they using it? Are they really using it a lot? Are they not using it at all? Are they using it to see a variety of conditions or only the ADD, ADHD type of things? And then we could say, well, these physicians are hitting it out of the park. What are those bright spots that we can then take with our physician champions or these new emergent leaders into those who are maybe struggling or more apprehensive about it? And then from a reimbursement perspective, I mentioned the billing and reimbursement. We were able to see denials, and we could take that data specifically back to payers and have those discussions about how we're improving access, how we're keeping patients maybe out of other facilities at a higher cost by video visit, and get the reimbursement conversation started around those specific data points. Lastly, and then I'll turn it over to Kacy, impact of COVID-19. We touched on it a little bit. We started with our first providers in September of 2018, our early adopters. From September of 18 to February of 20, we had about 200 providers live, and we had completed over 3,000 visits. When COVID hit mid-March, we quickly ramped up to all of our ambulatory providers, which was over 600 providers. And in 1 week, right after that ramp up, we almost tripled the number of visits we had done in the 18 months prior. So to kind of put it in perspective, this is our trend going up through the week of June 7th. First 2 weeks in March, you can see kind of normal weeks for us. And then in the peak, we're at almost 1,300 visits. That is a 16,000% increase, which to me is just, it's hard to fathom that's even a real number between those weeks. But because we had leveraged our own providers, we were able to meet this and meet this demand and give those providers an opportunity to still see their patients despite the clinics being closed. We see that it's come down to 5,000, 4,000 range, which doesn't surprise me. If you lay it on top of this, the in-person visits, the trend is the opposite, which is exactly what we would expect to see as we continue with the delivering care virtually. So I'll turn it over to Kacy now.
Thanks, Jenny. So the next thing we'd like to touch on is how we chose to expand the team effort in order to properly and to quickly expand our video visits during COVID. As Jenny mentioned, we knew we needed to get this into motion quite rapidly in order to maintain the safety needs for all of our patients. And we also knew that it was our desire to once again continue to use our internal resources, and that includes our team members. We began to look for teams that could rapidly transition to encompass this particular initiative into already existing workflows. So we looked for some specific skill sets in the team members, and we were looking for those teams that had effective communication skills, those who already had experience utilizing MyChart, not just from a scheduling perspective, but also to once again communicate with patients. We wanted teams that were known within our organization to have good rapport, not only with our patients and families, but also with our providers and our additional clinical team members. That was really important to us. We wanted to be able to unify everybody and really communicate between all members of this team extremely well. We knew we needed all of these elements because these individuals were going to be reaching out to our patients in an already stressful point in history and an especially stressful point in their particular healthcare situations. And we were going to be asking these patients to do something new and unique and perhaps something that they had never done before. As Jenny referenced in our graph on the previous slide, many of our patients had never had an opportunity to participate in a video visit before. So this was a little bit of an uncharted task we were asking them to do. So we first were going to ask this team to assist our patients with engagement and activation of our MyChart patient portal, which is how they were going to connect themselves to our providers through video visit. We then were going to ask this particular team to essentially teach patients and families in a remote and non-face-to-face format how to successfully not only engage in a video visit with a provider, but how to do that well. So as we began our research, we were able to locate a team, one of our own teams within our ambulatory quality department, and that particular team is made up of our clinical care partners. Our clinical care partners are indeed known throughout our organization for good communication skills. They do have the established level of rapport that we desired, not only with our patients, but also with our clinical team members and our providers. And they already had elements of MyChart embedded into their normal and current workflows. So they really had all of the target characteristics that we desired, and we were really excited to assist them in efficiently transitioning into this particular role. In addition, some of the preparatory education you would expect a team like this to need in order to successfully pull off this level of initiative had actually already occurred for them. So we'll see on the next slide a little bit more in depth how really well prepared they were for this task. So I'd like to share a quick snippet of the background of this team to provide additional insight into why they were already so well pre-prepared to assist with our video visit initiative. Our clinical care partners are a team of individuals who do indeed have clinical backgrounds, but rather than support our providers from a bedside or physical hands-on perspective, they support our provider network through a more telephonic and digital communication platform. Because of this, they had just recently taken advanced coursework on communication. In this course, they worked to identify not only their personal communication styles, but were coached in areas that they recognized as needing improvement. They received education on the art of active listening and also in crucial conversation management. So while the focus of this course was intended to support their pre-COVID workflows, the skills they gained were greatly beneficial to the video visit efforts that we were trying to roll out during the COVID pandemic, once again making them a really ideal team for us to engage in this process. So all of this, as mentioned before, happens at a very, very rapid pace. That typically would throw any team into a little bit of a tizzy. But fortunately, this rapid pace of outreach that was needed was something this particular team was already used to. They're accustomed to this rapid pace of outreach throughout the cycle of their normal workflows. And so this wasn't as big of a challenge to them as it may have been to other teams. The outreach and discussion with patients and families in their pre-COVID workflows also allowed this team to build positive rapport. They have a good reputation, noting that sometimes patients, other people can't convince to come in. A call or two from some of our CCPs who just have really great communication skills will kind of flip the scales, and we can go ahead and have those patients come in and visit us. We thought that if some of our patients had been contacted by someone they were more unfamiliar with, we may not have the same success rate. And we did indeed find a difference. That based on the rapport, the familiarity with the name of the individual, hearing a familiar voice on the other end of the phone did indeed sway a lot of our patients who maybe were a little bit more nervous to engage in a video visit than they really needed to be or we wanted them to be. So one additional element that we used to help prepare the team was the modification of existing scripting. Scripting, in addition to the explanation of what type of visit the provider felt this particular patient needed, would now have the additional element of, and while we are all supporting your efforts to stay safe at home during COVID, Dr. Funes would like to offer you a video visit to help you complete your med check. And, we like to pick on our Dr. Funes, and so that's just an example. But not all of the preparatory support that they needed had already occurred. So on the next slide, I'd like to touch on just a few extra steps we took to prepare this team. All right, so to further prepare them, we needed them to be able to successfully guide patients and families through a new experience. One of the things that we did for them was work with Jenny's team to get them video education. This provided them the sign-up process from the view or perspective of the patient. It was able to increase their clarity of direction with the patients and really took their level of confidence in speaking to this matter up to the next level. We were asking them once again to perform two very, very important steps: the sign-up process to MyChart, and then the engagement or initiation and participation in the video visit itself. We felt it was very important to do this because there's a huge difference in saying in a very vague manner, there's probably going to be a little blue box at the top left-hand corner of the screen somewhere, just go ahead and click on it, and being very precise and saying something to the nature of, if you look towards the top left corner of your screen, you'll see a small rectangular blue box. In that box, you'll see the word accept. Go ahead and feel comfortable and click on that button. So this was really integral in giving them the level of clarity and confidence that our patients needed to take this next adventurous step. The other thing we did was give them truly the gift of time. We softened some of their existing workflows. We extended some deadlines we had on the horizon. We worked with external partners to make sure we had some softening of some deadlines to give them that comfort in knowing they could take as much time as they needed. We're very blessed in our organization that we were able to do that. I understand that that may not be a possibility everywhere, but it was something we felt was important for them. These team members are also patients. So in the midst of the stress and the other things that they had going on with family, with friends, with their own personal health, we wanted to soften the blow a little bit and reduce their level of stress by allowing them to have the gift of time. We very quickly realized within the first week or even two that some of our team members truly had the gift of MyChart activation and video visit introduction. Their ability to walk a patient or a family through this process at a really high success rate was very evident, and they got really positive feedback from not only patients and families, but some of our provider teams. So we then created a small team of our subject matter experts, and we designed a way to funnel those patients and families that need a little bit of extra love and support to these specialized team members, so they could then take another few minutes, that extra level of loving care with these families, so they had that increased level of confidence in our ability to guide them through the process. So next, we'll kind of touch on how we decided to engage the patients a little farther. We now had the team in place. We now had some workflows in place, but we needed to take those next steps and determine how we were going to roll out the initiative. So we elected to take a more traditional triage approach. We were able to partner with yet another team internal to our organization, our data team, who assisted us in the identification of patients that were at high risk and that we really needed to connect with early on in the COVID experience to prevent them from ending up in the ER or even worse, in a hospitalized state. So what we did was prioritize lists of those patients, sent them out to the team members, and that's how we initially got our outreach begun. In addition, we worked to give these particular patients priority scheduling for our video visits because we knew how paramount it was to stay on top of their condition to keep them out of the hospital. One interesting workflow that actually evolved and came out of this pretty early on was actually recommended by one of our own CCP team members, and it led to the modification of an already existing MyChart letter that they had been utilizing to communicate with patients. In addition to the information already contained in it, we went ahead and added how to initiate a video visit with a provider once scheduled. And we also outlined some very important tips and tricks on how to get the most out of your video visit. We found this helpful because some patients had a little bit of lag time or even had to reschedule or even got nervous between the time they spoke to a team member for that coaching and the time they actually engaged in their video visit. So some of the details got a little blurry and a little fuzzy. They got nervous. They forgot what button to click next or what they needed to do. And providing them with this digital letter for them to refer to really helped us achieve kind of the next level of success with those visits. Much of what occurred rapidly or much of what occurred in our workflow shifts were very rapid and reactive in nature. We've already begun to look at our next steps. We'd like to take a more proactive approach to continuing these efforts and to be able to successfully offer video visits long-term into the future for our patients who need that service or just prefer that service. Some of the things we've done so far is look at the permanent inclusion of MyChart offering or activation in the CCP workflows. So essentially, anytime they would reach out to a patient for any reason, they would need to check our EHR, make sure the patient was engaged with MyChart, and if not, give them that kind of that one-on-one concierge experience of getting them plugged into MyChart and given some appropriate support. So even before COVID, this team often was involved in the scheduling of patients. They do have full access to all of the scheduling systems in our organization. So we want to go ahead and continue to encourage them. If a patient expresses a desire to have a video visit, we want to make sure that they continue to have the security clearance and the access to be able to do that, and also to continue working with our physician champions and our digital health team to know when it's appropriate to schedule it as a video visit and when we may need to take a second glance at that and have some conversation with our providers to make sure that our patients have the most appropriate visit possible. I'm going to turn it over to Dr. Funes for our look at our video visits from a provider perspective.
Thanks, Kacy, and thank you everybody for joining the call and allowing us to share our experiences with you today. Jenny obviously spoke to this already, but she identified early on that if we're going to be successful in our video visit initiative, we're going to have to engage our providers. And I'm sure we're probably the only organization out there that has providers who are a little bit resistant to change. She recognized that early on, and she was really a guiding force in figuring out what our strategy would be. And so she engaged me and a few other, I would say, committed change agents, I think is what she said, to really kind of make sure that we test drove the tech, that we worked out all the kinks to make sure that the experience was a positive one for not only providers, but for the patients and stuff. And so so that as we move forward, we could share that message that this is something that's working well, that people really are using, and they really very much enjoyed. So that beta testing was super important. We really quickly invited some tech-savvy early adopters to participate too. And these are the guys who, when they were young, popped open their Walkmans to see how they worked. They probably had a few computers at home, including one that they assembled from parts. Some ladies and gentlemen who were just really a little bit techie, a little bit more tech savvy, and told them, hey, we've got this new little tool if you want to be one of the first to use it. And of course, they jumped in with both feet, and they really let us kind of put the tech through its paces and make sure that the audio worked well, the video, the experience was good. They had beta tested before. It wasn't their first go around, and that was super helpful. We then went to meetings, groups of meetings of our pediatricians. I'm a general pediatrician, and we spoke with our internists and our family physicians first, and we basically went to them and shared our success and told them, hey, we have this great new tool. We invited a coalition of the willing to participate, and it was really key that our digital health team, including Jenny and one of the people who work with her, Karen Lacombe, they were with us for every new go live, literally sitting in the room at our elbows, making sure that we had all of our questions answered. If something went wrong, they quickly addressed it, really followed up with the patients really well to make sure that they were happy with the experience. And that was very key to our success and our ability to get new physicians to engage. After that, we really did some targeted rollouts where we specifically chose physicians and said, you're going to be next. We think you're going to do well with this. And we really picked one by one. And that allowed us to kind of get pretty fair, widespread adoption by early 2020. As everybody knows, then COVID hit. And even the people who swore they would never do it found their religion and were dying to do it. And then the problem became there weren't enough mics, there weren't enough cameras. And so we really had to scale up. And if it weren't for the work that Jenny and her team had done, I think we would have really struggled to scale up. But we were able to do it pretty successfully based on the fact that we knew that the platform worked. We knew that the patients were able to connect to it very easily and stuff. So that was super, super successful. Next slide. So what the strategy allowed us to do is it allowed us to identify hardware and software problems early on. So as we went to bigger groups, we weren't getting a lot of pushback about how this isn't helpful, this doesn't work. We were able to prove that, in fact, it worked very smoothly. And generally, when something went wrong, it was usually based on the patient side. Maybe they didn't have their Bluetooth turned off or something like that. So that was very helpful. It also gave us the opportunity to improve the patient experience. And along with hand-picking physicians, we also hand-picked patients. And so several of our patients were people that were kind of friends or family, and we're able to kind of do some test video visits with them, get feedback from them, and figure out what were the most common problems when we started on video visits. It also created some champions who could speak to how well this worked. And that was really, really key, because that the word of mouth spread of, hey, we got this great platform, my patients are loving it. That really created a desire for people to become part of our video visit initiative. And Jenny's right that if we didn't have that physician-to-physician transfer of information, I don't think we would have been as successful. But pretty soon, patients became our best advocates. I would see a patient of one of my partners on a video visit. They would go back and see their regular provider the next time and say, gosh, that was such a great experience with Dr. Chris. I love being able to do a video visit. Are you going to be doing those? When are we going to be able to do them with you? So that really helped what we call our pod-to-pod contagion, which we think was a really important part of our success as well. Next slide. So of course, there's always resistance to change, like we talked about, and some of the most common pushback we got was, my patient's not going to pay if they can't sit in the room with me, if I can't lay my hands on them and stuff. And we had to kind of relieve people of that misconception that people love going to the doctor, right? It's such a great experience. Having to leave work early, pick your kid up from their school, drive across town in traffic, park, in the middle of the rain, run to the clinic, have to sit in the waiting room until you're pulled back, then sit and wait for the doctor, all of that experience, right? The 10, 15 pages of paperwork they had to fill out. We quickly convinced people that nobody looks forward to that process. People would pay us to avoid that experience if they could. And that's borne out to be quite true. I was also told I can't possibly do a video visit because they don't have vital signs. How am I supposed to get vital signs? So we realized that in some cases, hey, vital signs are critical and we have to see that patient in person. But for a lot of complaints, we didn't need vital signs. And if we did need some, most people have a scale at home. Most of them have a thermometer. A lot of people now have blood pressure cuffs, and they can tell us what they got on their blood pressure cuff, which we verify when they come into the in-person visits to make sure that their cuff is working correctly. I was told I can't complete a video visit because I might need to listen to them or look in their ear or do a lab. And we were able to kind of convince people that you can do most of a visit most of the time, not all the time. And sometimes all you need to do is peek in their ear or swab their throat or collect some urine. And we could have what we call a drive-by or curbside visit where someone came to the clinic and we could run out to the car, look in the ear really quickly, never had to come into the clinic, never had to expose us to their germs, never be exposed to the waiting room, and still have a great customer service experience. And they'd go home, we'd call them back with the results, or we'd send an antibiotic through MyChart straight to their through Epic straight to their pharmacy, and had a great experience and stuff. We're told people are going to make visits for dumb reasons. They're going to schedule visits for things that aren't necessary and shouldn't be a visit. And of course, the first answer to that is people can do that now. None of our front desk people are clinical. They don't screen people out to see if you're worthy of a visit. And so, you know, we told them that that might happen, but better to do it via video than have them come all the way out here. We were told the opposite, that people would schedule things that shouldn't be seen. It was too emergent. And of course, the same thing could happen with an in-person visit. However, we did teach people early on in our classes when we went kind of more broadly with COVID. We told people, hey, look at your schedule. And if you see a video visit pop up on there, look at the chief complaint. Just make sure it's not something or a patient that you may feel more comfortable that you need to talk to and not wait till the end of the day to do a video visit. So we were able to do some education, and that helped on that complaint. We were told, how am I supposed to bill if I don't do a physical exam? So we do a lot of education about coding when we bring on a new provider and talk to them about billing based on time for appropriate complaints. And we talk to them about how up to a level 4 visit needs very little physical exam, and some of that you can do via video visit. And if they needed a more specific physical exam, they could do a curbside visit like we talked about, or be seen in one of our tents that we set up during COVID. And so that was a super important ability to give them that comfort. I was told over and over, my patients aren't tech savvy. They can't do this. And I know that those same grandmothers were doing, FaceTime visits with their kids. They were ordering things off of Amazon. A ton of people have smartphones. There are areas where we don't have the Wi-Fi. We don't literally have people that have the technology. And so some of our clinics came up with neat workarounds where they'd walk a tablet out to the patient into their car, and the patient could still do a video visit using our technology, or they'd show up to their local library, even which was closed with COVID, because if they were parked outside the library, they could get the Wi-Fi from the library. So we had some great solutions to that as well. And then the last thing we heard was, my patients just don't want this. They like seeing me in person. And COVID taught us very quickly that patients do love it. And it was super, the visits were well received. The feedback we got in our questionnaires were fantastic. So basically what we came down to is, this is our pitch. Like, our patients are in the digital space. You either meet them there or they're going to meet someone else there. And that became really apparent with COVID as well. And so people have kind of learned to trust us and now feel like, hey, this is where we need to be. This is what we need to do. We've been talking about MyChart and how important it is for years leading up to this. So we told them that to do a video visit, you got to be on MyChart. This is a great reason and way to engage people to sign up for MyChart, because every time someone's on MyChart, that means they don't tie us up on the phone. That frees up my MA to take care of the patient in the room. That frees them. They can send a picture. They can send a message. Everything that used to be a 30-minute phone call, now we can turn it into an in-person or a MyChart visit, and that a video visit, and that allows us to monetize something that we used to do for free. And the patients appreciate it. They're happy to pay for that because they get that face-to-face time with us. Also, I use the example all the time of a family of mine who lived right outside of town. They were about 30 minutes away. Mom had 4 young kids. She couldn't leave them at home, so every time one kid got sick, she'd have to bring 4 of them on what was a 1.5 hour, 2-hour round trip. She was so pleased when we did one of our first video visits with her, and she was just singing the praises of how great it was to be able to stay home with her kids and do that video visit and be home when it was done, and not have to get back in the car and drive with them, not have to leave a second time to go out to the pharmacy to be able to run out and do that, or have her husband pick it up on the way home. So I use that example all the time, and it was just one of the best, most meaningful examples to anybody who has kids. And last, we talked about how important it was to keep care within the family. So every time someone engaged with us with a video visit was maybe someone who might have run to an urgent care that was a little closer to their house, and this let them kind of be seen on our platform, have their notes saved, be able to close gaps and things like that. So it was really, really critical to make sure that we kept that visit in the family. That's all I have, so I'm going to turn it back over to Jenny.
Yeah, thank you, and I apologize for the slides jumping there. So just in summary, a few quotes, and I won't spend time on these, but this is pre-COVID. Last August, pandemic hasn't hit anywhere. The demand for virtual care is there. It's reached critical mass. It's time for the supply to keep up. I think we've just seen that prove true, even it's at a larger scale. The patients are starting to enjoy being seen from home. We need to be prepared for this to continue. I don't think we're going back to the 81 visits a week. This one I think is very telling because this physician was somewhat reluctant to do video visits because she was afraid she was going to lose that personal aspect. But now with COVID, she says video visits feel more personal because she doesn't have the mask. She can see more of the facial expressions. Another provider saying that they're a great way to provide access to care. This is one of our early adopters who's been with us from the beginning. And then lastly, a patient response. We did do patient surveys, and I will speak to some of what we asked the patients. But this one I came across on Facebook, which made me smile because it was unsolicited, and it's a mom saying, thank you for enabling a virtual visit so that my daughter could see her physician. So Ray, before we continue with any questions and answers, I'll just say thank you to the group and then turn it back over to you.
Thanks, Jenny. So hi, everyone. My name is Ray Diazon. Really quick, I'm going to launch a poll. This is just a really quick survey to see if people are interested in collecting CMEs from this webinar series in the future. So I'm going to go ahead and launch it for about 30 seconds. Please take a moment to fill it out. All right, great. Getting a lot of responses. You guys are awesome. Give it 20 more seconds. All right, and we're going to wrap up the poll. All right, thanks everyone. So I'm going to pass it back over to Becky Bounds, and I think we're going to launch into Q&A here. So Becky, go ahead.
I will go start with the questions we have. What percentage of your patients have the ability for these virtual visits?
All of our patients, it's 100%, and we've opened it up to new patients as well. So if you weren't seen by one of our providers prior to COVID, and so you're a new patient, we've now opened it up to anybody who wants to be seen by us can be seen virtually as well as in person.
And I will just say before the next question, there will be a recording of this and it will be archived. See a National Telehealth Resource Center site. Who in the office is doing the outreach?
So it's a variety. We've got Kacy CCPs that do the outreach. We have the clinic teams. They do it, in clinic. Sometimes a physician will say, hey, I want to do your follow-up visit by video. We can get you signed up on MyChart, get that scheduled and so forth. But we do have a marketing communications team that has done a lot of the heavy lifting with the actual outreach and notification to providers, either through MyChart messaging or social media or direct email, in-clinic messaging, and flyers and things, and then social media as well.
Okay. How do you measure the patient experience specifically related to virtual visits? And you mentioned that that you would talk about some of the things that
yeah, we send out
you ask patients.
So in MyChart, once a patient has completed a video visit or any kind of visit with our providers, they get an after visit survey. And so we took that existing after visit survey and we have a rule built that basically says if it was a video visit, we're going to also add these additional questions. And we ask such things as, we want to be very specific, how was the quality of your video? How was the quality of your audio? How did you join? Did you join by a desktop or an Apple device or an Android device? Those types of questions. And I know there was a question that came in asking for those questions. Happy to share those. It gave us an opportunity to see where we might have some pain points. And we did ask too, specifically, if your experience was anything less than exceptional, do you want us to call you? May we call you? And if so, what's the best number to do so? Because we want to follow up on those.
How do you help clinicians master the skills they need to engage patients through video feeds?
So Dr. Funes, I'll let you chime in. We've, the training was at the elbow was one of the ways that we really sat with them to help out. But Dr. Funes, do you want to speak to that?
Yeah, so when we were initially engaging new providers, when we were still in the kind of tech savvy mode, we were basically, physician to physician sitting elbow to elbow with them in addition to Jenny's team. And so we told them little things like, hey, look behind you, make sure what's on your wall. Is it something that you want someone to see? Is it in a quiet place where you won't be interrupted a lot? We talked about video visit etiquette, right? Not looking at the patient's picture, which was somewhere on the computer and it looked like they weren't paying attention. Don't type while the patient's talking. So we had some kind of FAQs, some video visit etiquette. And when Jenny quickly, when I tell you quickly, like COVID happened, we closed our offices and we immediately started doing morning, noon, and evening sessions with our providers who weren't already on there. And we built all this into the training. So it was very intentional and it really was highly supported by our digital health team. They found some information. They broke up the work so that everybody contributed a little part to those sessions. And we literally talked about how does the visit go, what's going to make it a good experience, what might make it a bad experience and stuff.
So how did you deal with those providers that were resistant to using the technology? That's one of the next questions.
Yeah, so everybody has that, right? We have people that are resistant to change. So what we did is we hit them from all sides. We're like, I'm happy to take your patients because they're going to want to do these video visits. So if you want them to become my patients, stay on the sidelines and I'll be happy to be their PCP. Basically, patients sold it. We talked about the value of it. We talked about how this is, again, like it's not my quote. It came from someone at a digital summit I attended, said, our patients are in the digital space. You can either meet them there or watch while they engage with someone else. And then we found that to be very true. Pretty quickly, the people who were slow to adopt looked to the side and saw everyone else was doing it. They were losing patients or not gaining patients. People on Facebook were sharing with their friends, oh my gosh, my doctor's doing video visits, this is great. And they quickly kind of stepped up.
We have time for just a few more questions. Have you implemented other services such as PT, OT, speech therapy via telehealth?
We have. We've enabled some of that directly through the Epic integration like we've talked about. And then if they wanted to have more than one participant in those sessions, we've also been able to leverage our technology out of the box, so not integrated with Epic, so that we could have multi-party and that kind of thing. So we have enabled it for those maybe non-traditional physician type providers. So yes.
So the next one is about how much time is allotted. So when you're scheduling these virtual visits and you said say the doctor goes in, this patient's ready in this exam room, and now the next one's a video visit, are they scheduled the same as far as time goes?
They are scheduled the same. So we have a pretty standardized template and 15-minute slot, 30-minute slot, 20-minute slot, whatever. So they do follow the same. So outside of COVID, right, just normal video visit world, we had some providers who it was just part of their workflow. They'd go in exam room 1 and then they'd pop in this other video visit enabled location, either their office or the exam room. And then we had some who said, I want to dedicate the last hour of the day, or I want to add an hour to my day and I'll see video visits then. So it varies, but they follow the standard clinic schedule.
Translator services, how do you deal with that?
Yeah, so the way we have our technology integrated right now with Epic doesn't allow for that integration as well. So we've had to basically do phone calls or have providers like Dr. Funes can handle a couple of different languages there. So that's something as we look to transitioning to the way we have the functionality integrated with Epic, we're looking to an integration that would allow us to have more of that language services incorporated.
Just a couple more. How did you navigate implementing video visits for new patients? Did you utilize patient portal for new patient intake, registration, and what are the barriers there?
So if it was a new patient, we got them activated on MyChart immediately, got them scheduled through MyChart, and I mean, so that it showed up in their MyChart account. And then to launch the video session, they needed to go into Epic MyChart and they would fill out all of the information that we needed. We would take some of the basics over the phone, but it was integrated with that process. So back to one of my first slides, talking about the virtual process replicating the in-clinic process, we would just, it flowed pretty naturally because of the way we had it set up.
Okay, and there's a question about the technology platform you're using.
We currently have video, VIDYO, integrated with Epic through their deep integration functionality, and we need to transition that to their context-aware linking functionality. For those of you who are familiar with both of those, when we started in this space, pretty much the deep integration with Epic was really our best option, but we are using video.
And it is HIPAA compliant and encrypted.
It is.
Okay. Noticed in the chat, Jenny, there was someone that wanted to connect with you. If you can see that, I'll just leave that with you.
I did reply, I think, to all the participants and panelists with my email address. If anybody wants to connect with me directly, my email address is in there.
And certainly if you have more questions, the very basic about reimbursement and that kind of thing, the telehealth resource centers would be glad to help you with that. We field a lot of those questions. So we do have this webinar series every month, and generally on the third Thursday of the month. And so the next one will be July 16th, and the telehealth topic is to be announced, but check all of our websites and we will put out more information as we have it. And thank you so much, Jenny, Dr. Funes, and Kacy for this presentation. This was great information.
Thanks for having us.
Yep, thanks, Becky.